Welcome everyone to this webinar, SEIR COVID-19 Compartmental Model, a model to gain insight into the effect of interventions on outcomes. Thank you for joining us today. My name is Margaret Howarth-Brockman and I am with the National Collaborating Centre for Infectious Diseases. I will be your moderator during this hour. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. Before we start, I would like to acknowledge that NCCID is located on original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Today's session provides an exploration of the SEIR model developed by modelers at the Public Health Agency of Canada. NCCID and PHAC are partnering to share models and supporting information for users across Canada. You can see all of the related resources at nccid.ca, and there are additional materials in development. So now I'd like to introduce today's speaker. Aamir Fazil is Chief of the Risk Integration Synthesis and Knowledge Section at the Public Health Agency of Canada. Mr. Fazil holds engineering degrees from Drexel University and has been working in quantitative microbial risk assessment for more than 20 years. This includes being a primary contributor to several World Health Organization, Food and Agricultural Organization microbial risk assessment simulation models. Together with other scientists at the agency, he contributed to the development of the COVID-19 SEIR model. In today's presentation, Aamir will explain how the model works and how you can adapt it for your local needs. We'll run the presentation and then he will be available live to answer your questions.
Hello, everyone. Today I'm going to be talking to you about an SEIR model that we developed at PHAC to provide some initial insights into the COVID pandemic. What I'm going to be describing is one of the models developed at PHAC. We've got a suite of models that have been developed, and those will also be shared on the NCCID site over the coming weeks. This particular model is a very traditional compartmental model. It was developed in Analytica, primarily because Analytica is a tool that allows you to do a rapid development of models. It's also relatively graphic in terms of the way models are structured. They use inference diagrams to draw relationships between parameters. And so it allows model construction to proceed in a relatively insightful way, especially when you're dealing with both a technical audience as well as perhaps subject matter experts that can provide some back and forth communication. The main focus of this model was to gain additional, basically to gain some insights into what was happening, get some advice in terms of what might need further refinement, and hopefully inform some of the additional model development that we would proceed with. So the overall objective of this webinar will be just to give you an overview. I'll, after this series of slides, walk you through the model itself in Analytica. I'll show you how to use the model, where some of the inputs and outputs can be accessed from, how to understand the model itself, and then show you some of the results and some of the nuances around interpreting some of those results, so that hopefully you'll be able to have a better understanding of the model and maybe even modify and apply the model as appropriate for your situations. So the overall structure of the model is, as I said, it's a compartmental model, and a very traditional SEIR model. So we're looking at susceptible, exposed, infectious, and recovered/removed populations within this model. That's shown on this slide on your screen now, where you have the population that's susceptible, potentially getting exposed to the infectious population. They then moved into an exposed category. The exposed people eventually become infectious themselves. When they are infectious, they can either be symptomatic and severe, symptomatic and mildly ill, or asymptomatic. When the model was constructed, there was really a large degree of uncertainty at the time with what proportions were in what compartments. And if you've kept up with the literature, even today, there is still ongoing uncertainty as to what proportion of the population is actually asymptomatic, what proportion is mild, what proportion is severe, what the relationships are between those components and potentially different demographics in the population. So while we've learned a lot, we're still learning. And that, in essence, is, for the most part, the story of modeling COVID in this epidemic across the globe is the constant generation of new knowledge, the constant refinement of models, and the need to always look at the new evidence, apply that evidence to the models, because what you constructed a week ago can a lot of times become outdated. So you need to be constantly evaluating your parameters, the values, etc. So all the values you see that we might discuss in this webinar shouldn't be taken as fact and accurate for eternity. Things will change, and so you should sort of scrutinize any of these values given what's known at the time that you're going to be applying the model. What we have done within the model is used what were considered to be best estimates at a certain point in time. In Analytica, you can apply uncertainty distributions as well in your model, and I'll demonstrate, or at least I'll show you where you can do some of that. And that in essence is good practice for the most part, is you want to capture uncertainty in your parameters. So overall, this picture shows you what the general structure of the model is. And this slide shows you what you will potentially see when you open up your Analytica model. So having given you that overview, I'll switch over to Analytica now and just walk you through some of the modeling process. So this is Analytica, the model opened up in Analytica, and this is typically what you would see when you open up the Analytica model. This is your input screen, if you will, and it's broken up into a couple of sections that are probably appropriate to explain. You have your input parameter area. This is where you would enter the input parameters, or what you know about either the population or the pathogen of interest. So you've got things like contact rates, how often people are on average contacting each other, the latent period of the infectious of the infection, the infectious period of the pathogen, the symptomatic proportions, proportion severe, and time till hospitalized. The blue boxes represent some crude or general interventions, non-pharmaceutical interventions, or NPIs. These would represent public health measures that might be implemented, that you might be interested, and we were interested in sort of looking at to see what effect different strategies might have on the general epidemic trajectory. There's the results section, which by clicking one of these buttons will generate appropriate results, and from there you can sort of explore the interventions, you can explore the results, you can generate curves and get some insight from them. And then the large blue box here gives you access to the actual model itself, the logic in the model, and how the equations are structured, how parameters interact with each other. Just to give you a little example of that, I'll open up the model structure. And when you do that, this is where you see, if you will, the real machinery behind the model. This is in essence an influence diagram, which I mentioned early on. Analytica is constructed primarily using influence diagrams. And what influence diagrams are, while you might be tempted to think of them as a flowchart, they are not a flowchart. They represent how parameters influence other parameters. So the arrows don't necessarily represent a flow of either the flow of people or flow of things, but rather they show how one parameter influences another parameter. So for example, in this particular case, you can see the delta susceptible, which is the change in the susceptible population, is influenced by the transmissibility with contact, or the probability of infection when someone comes in contact with an infectious person. So that's how you should read the diagram, is a bubble and an arrow pointing to another bubble tells you that that bubble has an influence on the receiving bubble. So what you find when you open up one of the bubbles is a description of what that particular parameter is. In this case, as I said, delta, the variable name is DE. What the title is, there's a description of what is happening in this particular thing. In here, we see it estimates the rate at which exposed people move into the infectious category. And it then gives you the equation as to how that parameter is influenced. So you can see it's 1 over the latent period times the exposure to severe parameter. All that to say, Analytica is a very graphical display of how the model works. So you can quickly see how a parameter influences another parameter. If you open up that parameter, you'll get the additional details of what's happening behind that value. And that would apply for everything within the model. It would allow you to see every parameter, what the implications are of that parameter, how it influences other parts of the model, and which parts of the model influence it. So having said that, we'll just spend a little time exploring some of the results and showing you how things can work. I did mention that this is where you have your input parameters, and Analytica does allow you to use distributions of values that could represent your uncertainty. So for example, right here, we've used a contact rate of 10. That means that each person is having on average 10 contacts a day prior to any social distancing interventions that were applied. In theory, you could apply a distribution in here. So for example, you could use a normal distribution, a uniform distribution, any distribution that you might think represents the uncertainty. You could enter a uniform distribution here that says, you think that it should be uniform anywhere from 5 to 15 contacts per day. And if you did that, you would then have to run a Monte Carlo simulation on the model, and you would produce distributions of values. For the purpose of this explanation, we'll just stick with fixed values, because the other advantage of Analytica is it does allow you to do a little bit of parametric analysis at the end. So in some cases, it allows you, for example, a contact rate reduction. If you click on that, you'll see a whole range of values. And in some ways, when you select all, what you're doing is you're telling the model that you want to test out every single combination of contact rate and produce a result for that, for yourself, for the user to test out, what implication does it have if contact rate was 20% less versus 40%, et cetera. You'll have access to all those scenarios when you view the results. So in some ways, you are capturing a little bit of a combination of both uncertainty and a little bit of a scenario analysis is all being done when you click on result. So just to test, or just to explore that a little bit, we'll look at some of the results. First one would be, for example, the daily incidence. If you click on that, what you get is your very traditional epidemic curve that most of you are probably reasonably familiar with. It shows the daily incidence of cases as time progresses, with a certain number of input or a certain combination of input parameters. So in this case, we've assumed that we're looking at a 20% reduction in contact rate. And as I mentioned a few seconds ago, you can look at alternative contact rate reduction. So in this particular case, we've got, if we put 0 here, that represents the incidence if contacts were maintained at their standard level. So 0, you can look at a 10% reduction, a 20% reduction, 30%. So what this shows is the effect of changing contact rates in the general community, and what that what implications that would have on the daily incidence of disease. What's perhaps more interesting or easier to understand is you could potentially also just plot them all on one curve, and that makes it a lot more easier to understand. So you've got your original incidence curve, you've got the implications associated with changing contact rates. So that allows you to have a quick look at what effect does contact rate reduction have on the overall incidence curve. And you can clearly see a reduction in the peak and a spreading out. So essentially what you're doing is you're reducing the highest number of cases or the highest number of incidents that could occur in any one day, but essentially stretching it out over a longer period of time. In addition to contact rate reduction, you could look at other things. So for example, what would be the implications of the duration of time it takes for a test result? How much of an effect does that have on the incidence curve? And so if I change the plot over here, you can see I changed it to time for test result. And you might say, well, that didn't really do anything. And the reason it hasn't done anything is because the proportion of cases detected is currently set at 0. So if I change that to 10%, 20%, for example, you can see what effect that now has. That shows you that if you were detecting 20% of your cases and you were able to get test results within 1 day, 2 days, 3 days, 4 days, etc., that's what the effect on the epidemic curve would be. Interpretation there obviously is that if you are able to capture infected individuals and isolate them in a rapid time, they are no longer in a position to spread infection within the community in general. And so you start to really bring that curve down. Obviously, all of that is assuming right now, so you've got 20% contact rate reduction. There's no contact tracing going on. Sorry, there was 20% of the proportion of cases are detected. Time for the test result is shown in each of these curves. And that's what would happen, and there's no contact tracing. If you implement contact tracing, it adds additional effect. So for example, as you add more and more contact tracing, it only improves the process even further. As I said, it's a relatively simple initial pass model. So there is obviously going to be a relationship between your ability to contact trace and your ability to test. What the model currently doesn't have, or at least this model doesn't have, is the relationship between the two. They're handled independently, and it's up to the user to sort of make sure that you're entering logical value. So for example, there's nothing in the model that would tell me that I can't have 100% contact tracing and 0% testing. But logically, that would make absolutely no sense. In essence, I could, for example, in essence, have a setting in here that says 0 proportion of the cases are detected, and I could go into, for example, we'll do contact rate. So we'll do contact rate. Let's do this time to contact trace. The time for a test result here is set to 7. Contact trace effectiveness is at 10%. Proportion of cases detected is 0. So essentially what this setting is telling you is I am detecting no cases. So my testing is virtually useless. My contact trace effectiveness is at 10%, or let's go to 20% just to make it more dramatic. Contact tracing is at 20%, and time to contact trace are each of these curves. Now, logic would tell you that if you are detecting no cases, it's highly unlikely, well, virtually impossible, that you'd be contact tracing 30% of the population. But the model is not structured to have that link made between, you have to test a certain percentage in order to effectively trace a certain other proportion. That's left up to the user using this relatively simple model to interpret the results with caution. And that's what I want to convey in this portion is you need to have some logic when you test out various scenarios. And this would be a prime example of the classic garbage in, garbage out. You can come up with combinations of values that don't make sense from a real world perspective. So you should always interpret the results coming out with a little bit of common sense and public health insight. Okay. So having said that, like I said, there are various other results that you can generate. That was daily incidence. You can produce results that show the total attack rate. So this essentially is just a cumulative curve that shows how many people at the end of the epidemic, what proportion of the total population would be affected. So similar to the previous curves, but just showing the final attack rate. This too, you can plot using different curves. So for example, let's say we wanted to see what the testing effect had on the final attack rate. You could look at time test results. The contact rate reduction here, we can set that to 20%. We'll eliminate contact tracing. So contact trace is set to 0, time to contact trace is 7. Proportion of cases detected, let's just reduce that a little bit so that we say essentially 30%. So we have a testing program which has various time delays that we want to explore, and we want to see what impact that has on the final attack rate. And so you can see here with the pink line, that's 7 days. And after 365 days, you would end up with almost 65 or so % of the Canadian population essentially affected. So this would be, you are doing nothing, but the contact rate is reduced by 20%. So people are socially distancing a little bit. And you are doing nothing else except in 30% of the time, you are isolating sick people. Now, this is probably not a realistic scenario either, but it helps at least to understand, well, if I could only speed up, if my only tool was speeding up testing time, and I kept it at 30%, so I'm still only capturing 30%, and those 30% get isolated so that after a certain number of days, I find them and I stop them from spreading infection more. That's what the effect would be on the final attack rate. I could have a pretty significant reduction going from more than 50% down to under 10% just by speeding up the process. Obviously, the next stage would be, well, is it in fact feasibly possible to do testing and isolation in 1 day turnaround? That becomes the next challenge, but at least you get some insight as to, this is something that may be worth exploring further, and then we can figure out how to actually make it happen. So that's attack rate. And similarly, you've got various other inputs and outputs that you can explore. And that's all of these buttons. I will point out, in fact, that if you are to open up the actual model and you wanted to look at the result for any of these bubbles, you can also do that. So for example, if I clicked on the exposed, you'll see below here, I get two little additional bubbles. If I click on the green one, that's a result. That will basically show me what the result for that particular parameter looks like for various settings. So the results in your front end screen here, these results, you're not restricted to only producing those results. If you are interested in looking at any other intermediate parameter, all you have to do is open up the model, you click on the value once, and you can click on the green button down here, or up on the top, there's a similar show result. If you click on that, that'll show you what the mid value for symptomatic severe looks like. So whatever that parameter is, it'll show you what that looks like. You can similarly play around with changing every parameter that has an influence on this parameter will show up on the top of your screen, and you'll have the ability to modify that and see what impact that has on the result. The underlying message, as I said earlier on, though, is you should always put some caution into the model doesn't restrict you necessarily to different combinations. You can produce some combinations which don't make practical sense. And so you should always have that in the back of your mind. And that would conclude the presentation of the PHAC compartmental model constructed using Analytica software. Thanks.
Thanks very much, Aamir, for this presentation and demonstrating how to use the model. We're now going to begin our live question and answer period with Aamir. So Aamir, our first question that came up in the course of your presentation was, what were your data sources in developing the original model? Have you been rerunning the model as the epidemic dynamics change in Canada?
Thanks. Yeah, so at the onset, a lot of the information was derived from the published literature. So essentially, we were when the model was initially developed, we have a team at PHAC that was combing through both pre-publication literature to derive as best as we can some of the input parameters. As I said, that has constantly evolved as time has gone on. What we did do is this model was intended to serve as the initial sort of template, if you will, to think about what needs to be captured and how the trajectory might look. So we developed this model, used initial information from the published literature, as well as what was known at the time in Canada. Eventually, this model has started to be used less, and we've moved into deploying other models that are a lot more suitable to purpose, and they'll be, as I said, mentioned, shared on the NCCID site eventually. That includes agent-based modeling approaches, as well as a more complex SEIR model that has age stratification and has been fit to epidemic real-world sort of surveillance data.
Okay, thank you. The next question that arises is, are provinces or territories using their own models, and are they similar or different from the model and the impact on the modeled outcomes that you've been talking about? One example, I guess, given is Saskatchewan's compartmental model.
I think all provinces, well, not all, but most provinces have their own models that they've developed internally. We also have been across Canada, we've sort of been partnering and sharing models and ideas. So in certain situations, for example, I mentioned the agent-based model, that has found sort of application in other provinces as the needs have arisen. But for the most part, many provinces have their own models that have been developed. When requested, models have been shared to sort of help in the decision-making process. But obviously, as we all recognize, the parameters and the nature of the epidemic in different provinces requires a little bit more nuance in terms of the population that is being affected in a certain province would be very different than another province. And taking a very federal view, you can't necessarily go down to that level of disaggregation. So it's very important, I think, that most of the modeling or the insights are gained at a possibly provincial and territorial level, if not even lower level than that.
Thanks, Aamir. I think that leads into the next question that's arisen. The question is, if I manipulate the input parameters or other features, as you've been describing in Analytica, will I be able to save for our use? And what about changes to the model itself?
So, sorry, could you repeat that again, Margaret?
The questioner is asking, if I manipulate the input parameters or other features, as you were describing in Analytical, will I be able to save it for our own use? And what about changes to the model itself? Or is that set, I guess is the question.
Yeah, so the current, like I said, I mean, unfortunately, this Analytica is a proprietary software. So with the free viewer, you're able to look at the model, you can run the model, you can save the results. You could change input parameters and produce results that correspond to those input parameters. However, with the free version, I believe you are restricted in terms of not being able to change the equations or the structure of the model. That would be the only restriction. But for the most part, the intent here is to be, as I had mentioned, when you open up, I believe everyone can see my screen at this time, but when you open up the details of the model, if there was an absolute desire to recreate the model in, for example, another software that you have available, then there should be enough information in this screen, including all the necessary equations, that would allow you to recreate it if you had to. However, as I mentioned, this was a model that was designed to give you initial insights into the potential trajectory, the potential impact of various interventions. And so I can't imagine there would be much need to dramatically modify the model. There might be a need to test out alternative scenarios and look at what that looks like. But then you would probably be encouraged to sort of develop a model that is a lot more, perhaps detailed and perhaps more specific to the region or the location to which the model is being applied, including considering things like age stratification. And some of those models will be shared in the next few weeks. Like I said, another SEIR model, which has age stratification and is developed in R, that one will also be shared here. And those might be sort of more appropriate for that purpose. I think this model is most appropriate to get a quick overview or a quick insight into what the impact of various interventions are, what could or how significant might the trajectory look like in your particular area, depending upon various assumptions.
Thank you, Aamir. I'd just like to encourage everybody again to enter your questions on Slido if they occur to you. In the meantime, just to give everybody just a moment or two, Aamir, is there anything else you'd like to add? This particular presentation was recorded a little bit earlier, and I know what it's like. Sometimes there's a second thought about anything that you think that would be of interest to the audience members.
Yeah, I think another sort of, I touched upon the idea of, entering uncertainty distributions, and that would be, I think, an important consideration as well. Whenever we produce results from models, at least the ones that I demonstrated here, there was, for example, we have a curve that looks like this. The epidemic curve is simply a best estimate based on the individual best estimate input parameters. Ultimately, all those parameters have uncertainty and, in honesty, variability associated with them. And so, it would be best practice, as I mentioned, to have probability distributions defined for your input parameters. Once you have those probability distributions defined, you would have to go under uncertainty options here. You would define how many sort of iterations under sample size. You would define how many iterations you want the model to run. So if you entered 1,000, for example, the model would sample from each distribution, run the model, produce results, resample from the probability distributions. And ultimately, what you end up with in the result would not be just a simple line, but it would represent, you would end up with a cloud of epidemic curves, if you will, that you can interpret to represent, this is the range of results that you would expect given the uncertainty in the input distributions. Now, it's important to recognize that is, again, really just an uncertainty distribution. It's not a stochastic model in the sense that many of you might be thinking. When you run an agent-based model, for example, there are very stochastic sort of elements associated with that represent, the epidemic dying out due to probability sort of events. That wouldn't necessarily be captured in a model like this. But at least by putting probability distributions, it allows you to recognize that there is, there's a range of possibilities just driven by our uncertainty in those input parameters. And as we've been discussing, the nature of information in this particular outbreak is evolving daily and weekly for sure. So it's important to capture that uncertainty.
Yes, evolving almost hourly, it seems sometimes. That does seem to have brought us to the end of the questions that people are posing for now. So I would like to take a moment to thank you, Aamir Fazil, for joining us again. It was an excellent seminar, and we really appreciate the time you've taken today, not only for this presentation and webinar, but also working with NCCID to develop the additional materials. Information related to mathematical modeling for public health and this SEIR model in particular can be found on our website, nccid.ca. This webinar is part of a series that NCCID is sharing on mathematical modeling and COVID-19, the Synergy series. The next webinar will be September 11th and is titled COVID-19 Vaccine, Outlook and Opportunities for Modeling with Dr. Joanne Langley. For information on all of these and to obtain a copy of the recording of this presentation, you can visit us at nccid.ca or at Center Infection. Please stay well and safe. Thank you.